Good morning, everyone. Pediatric life support. I'll just to recap. I'll go through the basic things. So A, B, C, D, E, right? A, B, C, D, E. But in the structured approach, because when there's a trauma history, we start with C, A, B, C, D, E, right? C, A, B, C, D, E. C is for catastrophic hemorrhage and cervical spine, right? If there's a large amount of bleeding, we have to stop the bleeding, and we have to stabilize the spine. Cervical spine, and then airway breathing circulation. Otherwise, if there's no trauma, we can start with airway breathing circulation, disability, and exposure. These things we have seen last time, so I'm not going to repeat it. um, just going through those things. And so we saw that a patent airway does not ensure adequate ventilation. So we need to, while assessing A, we need to intervene A, right? So we can't say we assessed A, B, C, D, E, and then we intervene like that, not like that. So when we assess the A, we have to intervene for the A. We assess the B, then we have to intervene for the B, right? So every time we assess these things, we have to do the intervention also, right? We saw primary assessment and secondary assessment. Primary assessment is the life-threatening conditions we are assessing and intervening at the same time. So if it is primary assessment, airway, breathing together. We saw effort, efficacy, efforts. Then primary assessment, circulation, cardiovascular status, effects on other organs. Then disability, exposure, like that we came. And then interventions for the airway, and primary assessment of circulation. I'm just repeating it again, just for you to keep it in the memory. So um, primary assessment of disability, and secondary assessment. Secondary assessment, you go into a little bit detail and recognize the problem and intervene for that. Right? So that also we have checked, we have done last time. So we saw like mouth to mask ventilation. So this is the mouth to mask, right? So after the COVID and all, we don't do mouth to mouth most of the time. So there is a gadget for mouth to mask and to ventilate. So this is the gadget. And then we are familiar with the bag and mask ventilation. Capnogram, this disposable capnogram usage we discussed last time. And then we discussed about the oropharyngeal airway insertion, right? Oropharyngeal airway insertion. So all of you working in the emergency, you know how this is used, how to size these oropharyngeal airways, and how to insert it, right? Um, so then we looked at the nasopharyngeal airway insertion, how to size the nasopharyngeal airway, and how to insert, and the indication, right? So today we'll look at some basic principles of endotracheal intubation and rapid sequence induction, right? So I'm not an expert in this, but everyone should know a little bit of basics about intubation. Um, so Um, so, Important thing is all children should be anesthetized and paralyzed before laryngoscopy, right? So we should anesthetize them and paralyze them before laryngoscopy. If not, if they are struggling, then it will be very difficult to intubate. Not only it will be difficult, um, but if we don't anesthetize and paralyze before laryngoscopy, you can have unwanted effects. Child will be struggling. There can be trauma, like loss of teeth. There will be blood in the throat, and sometimes vagal stimulation can cause problems. There can be bradycardia and problems. So we should always try and anesthetize the child and paralyze the child before intubation. And all the team members should understand what their role is, right? So everyone should not attempt to intubate, right? So everyone should not attempt to get the plaster or something, right? So one person for the plaster, person for the drugs, one person for the neck stabilization, like that. Everyone should do their job, right? So equipments and drugs must be organized, readily available, and regularly checked. So most of the time we see this as a problem. All who have intubated, you have come across this problem. Like the batteries are weak, the bulb is not working, correct size blade is not there. So these are very common problem, right? So that is why in your wards, make sure you have this checklist, right? And every morning you are looking at the checklist, right? So am I correct? All of you have emergency trolley. Do you have a checklist, right? And do you check the list every morning, right? Okay, so every morning you have to check the list, and all the equipments should be in working order. And if you have any problems, you have to add that to the checklist next time, right? If the one resuscitation there was a problem, you have to go and add that to the checklist the next time to check it, right? So um, so um, Another thing is, even though we say the child should be anesthetized and paralyzed before laryngoscopy and in endotracheal intubation, we don't expect you to do this when a child is in cardiac arrest, right? If the child has come and if the child is fully arrested, right, then and you don't have to do this, right? You don't have to give the anesthesia and come. You don't have to give the anesthesia. You don't have to paralyze the child. Why? Because the child is arrested, no, already arrested, right? And child is arrested, and the tone is completely gone, and you can just straight away intubate, right? If the child is like clenching the teeth, or like if there's a the problem, then you have to do something about it. But if the child is not alive or just arrested, then you have to intubate and resuscitate if you want to intubate, right? Otherwise you can do with the bag and mask, right? If you are unable to intubate, then you can go ahead with the bag and mask, right? So if you paralyze a child who is like who is just terminal, that is going to get arrested or almost arrested, then sometimes that will your drugs will affect the resuscitation, right? So that might be a problem. So you have to be careful about that also, right? So these are the indications for intubation. Failed or inadequate basic airway management. So we have seen the airway, bag and mask positioning last time we saw, sniffing position for bigger children, neutral position for infants. How do you keep the mask how do you position the child. So if you can't hold that position, if that position is not sustainable, if the airway is not getting, chest is not moving, and you are not able to maintain the airway breathing, airway and breathing, then you have to go for the intubation. So before that, in between, there are two options. No, what are the options we saw? Like basic bag and mask, holding the mask, as well as before intubation. In between, what are the things that you will try? Quickly, someone tell me. What are the things you will try? Like the mask and positioning and mask, right? Then what are the airway maneuvers and adjuncts that you can try before going for intubation? Huh? Yeah, very good. Chin lift and jaw thrust, right? And double-handed chin lift and jaw thrust. So one person do both sides, right? Double-handed chin lift and jaw thrust, and then one person doing the bagging, right? So that is one maneuver. What are the adjuncts you have? Quickly, someone from the back shout adjuncts, right? What are the airway adjuncts that you have? You all know that. Just tell it. I know all of you know that. Just tell it. Divanika, airway adjunct. Huh? Adjunct is the what something that is helping you, right? ADJUNCT, right? Adjunct. What is it? Yeah, tell. Huh? Shout it. Can't hear. Oropharyngeal. Very good. So why are you keeping it? Right? All of you know, I know this. You know this, but just tell it out loud. So it's called Godel, Gedel or Godel, right? Whatever, Yahweh. And so oropharyngeal Yahweh. So what is the one nasal one? Nasopharyngeal Yahweh, right? And then in between the intubation, if you are not a skilled intubator, there is something called anybody anesthesia people, laryngeal mask airway, LMA, right? Laryngeal mask airway, right? It has a weight, and you just have to insert it in the direct position, right? And similar to laryngeal mask airway, there is something called eye gel, no, eye gel. So I have not seen that. There's a new thing also. Right. So these are something like intubation, right? So you Google and see this IHL. So these are the failed airway management is one reason, and the GCS less than or equal to 8 to protect the airway, right? So this is a very important aspect. You have to protect the airway in low GCS, right? Low level of consciousness. If you are able to assess the GCS, last time we saw, if you are able to assess the GCS, you can do that. E4 V5 M6. You should know that what is E4 V5 M6. You should know.